Digestive system, and we're basically going to follow food from the start of the digestive tract to the end of the digestive tract, one organ or group of organs at a time. And we'll begin that with the mouth. The mouth is where food is chewed and mixed. It's also where it's first introduced to saliva that contains enzyme in it. And most of those enzymes in the saliva are going to be breaking down carbohydrates for us. However, there is some small amount of lipid processing involved. And the mouth has organs associated with it: the tongue, the salivary glands, and the teeth. But the mouth is also called the oral cavity or the buccal cavity. It's bounded by the lips in the front, the cheeks on the sides, and the palate above, and the tongue below. The oral orifice is the anterior opening, often referred to as our mouth. Its walls of the mouth are lined with stratified squamous epithelium, tough cells that resist abrasion. And the hard gums, hard palate, and part of the tongue are keratinized in addition to that for extra protection. The lips and cheeks, the lips, in Latin labia, are composed of fleshy orbicularis oris muscle. The cheeks are the buccinator muscles. The oral vestibule is the recess internal to the lips and cheeks, external to the teeth and gums. If you happen to be someone who chews tobacco, that's where you put your tobacco. But if you are, please quit and don't ever start if you're not. The oral cavity proper is within the teeth and gums, and the labial frenulum is the median attachment site of each lip to the gum. And they are pointed out here, figure 23.8, which I encourage you to look at in your text. The palate is going to form the roof of the mouth. It has two distinct parts. The first is the hard palate, which is formed by the palatine bones and the palatine processes of the maxillae, and it has a midline called raphe, and the mucosa is slightly corrugated, and that helps to create friction against the tongue, involved in just breaking down food. The soft palate is formed mostly from skeletal muscle. Its jobs include closing off the narrow nasopharynx during swallowing. On the sides, the soft palate is anchored to the tongue by the palatoglossal arches. It's also anchored to the wall of the oral pharynx by the palatopharyngeal arches. And the area between those arches is called the fauces, and the palatine tonsils are located in the fauces. The uvula is that finger-like projection that faces downward from the free edge of the soft palate in the back of your mouth. Is the uvula and the other structures of the oral cavity. The tongue occupies the floor of the mouth. It's composed of an interlacing bundle of skeletal muscles. Use the tongue to grip, reposition, and mix food during chewing. When we are chewing, we are going to form that food into a mixture with saliva that we are going to call a bolus, and it's that bolus that we will swallow. So the tongue is involved in forming the bolus and initiating swallowing, and it is also involved in speech, and that's where we find many taste buds. The extrinsic muscles change the shape of the tongue, while the extrinsic muscles alter the tongue's position. And the little piece of tissue that attaches the tongue to the floor of the mouth is called the linguinal frenulum. The superior surface has papillae, which are peg-like projections underlying that mucosa. They are filiform papillae, which gives the tongue roughness and provides friction. Only ones that do not contain taste buds. They give the tongue a whitish appearance. The fungiform papillae are mushroom-shaped. They're a little wider on the top with narrower stalks. They're scattered widely over the tongue. Their vascular core causes a reddish appearance of the tongue. The valate or the circumvallate papillae there's 8 to 12 V-shaped rows in the back of the tongue, and the foliate papillae are located on the lateral aspects of the posterior part of the tongue. The terminal sulcus is the groove between the groove located posterior to the valate papillae papillae, and it marks the division between the body and the root. The body being the portion of the tongue that's in the oral cavity, and the root is the posterior 1/3 that resides in the oral pharynx. This doesn't contain papillae, but it's still bumpy because of the linguinal tonsil, which lies deep in its mucosa. So there's that structure we're talking about. Ankylosing is a congenital condition in which children are born with an extremely short linguinal frenulum. It's commonly referred to as tongue-tied, sometimes fused-tongued. It restricts the movement of the tongue, which distorts speech, and that can be treated by surgically snipping the frenulum. Salivary glands. Function of saliva is to cleanse the mouth, dissolve food chemicals for taste. Remember, the taste requires chemicals to be dissolved in a water-based medium, that is saliva. Helps to moisten the food, compact it into the bolus, and it begins the breakdown of some things in the food, most particularly starches. It has an enzyme called amylase, and amylase breaks down starches, which are long chains of carbohydrates. Most of the saliva is produced by the major salivary glands, which are called extrinsic because they're outside the oral cavity. But there are some minor salivary glands that are scattered throughout the oral cavity, and they help to augment saliva production. The major salivary glands are the parotid, the submandibular, and the sublingual. Parotid are anterior to the ear, external to the masseter muscle. The parotid duct opens into the oral vestibule next to the second upper molar. The submandibular is medial body, is medial to the body of the mandible. Its duct opens at the base of the linguinal frenulum. The sublingual is an anterior to the submandibular gland under the tongue. It opens through 10 to 12 ducts onto the mouth floor. Here is a microscopic view of salivary glands. You can see the mucus cells and the serous cells. Salivary glands are composed of serous cells and mucus cells. The serous cells produce a watery secretion with enzymes in it, ions, and a little bit of mucin. And mucus cells produce mucus, producing the mixture we call saliva. The parotid and the submandibular glands are mostly serous cells. The sublingual gland is mostly mucus cells. Xerostomia, or dry mouth, is an uncomfortable condition caused by too little saliva being made. Normal salivary gland function is vital for oral health. The lack of moisture can lead to difficulty with chewing and swallowing, as well as oral infections, and this can be caused by medications, diabetes, HIV/AIDS, Sjogren's syndrome, which is an autoimmune disease that affects moisture-producing glands throughout the body. So those salivary saliva is composed mostly of water, as all of our liquids have been in the body. This one's 97 to 99% water. It is hypoosmotic. It's slightly acidic, has a pH between 6.75 and 7. The electrolytes, major electrolytes, would include sodium, potassium, chlorine, phosphate, and bicarbonate. The salivary amylase breaks down starches, and there is also some linguinal lipase, which breaks down some fats. The proteins you would find in it include mucin, lysozyme, and IgA. Remember, IgA is an antibody. Lysozyme is an enzyme that is antibiotic. Metabolic wastes are also found in saliva, including urea and uric acid. In addition to the lysozyme and IgA, there are defensins, some nitric oxide, and that helps protect against microorganisms. Here's a rotating head to give you an idea of the position of these things. Controlling salivation, how much saliva we produce each day. Typically, we produce about 1.5 liters. There are some minor glands that work continuously to keep the mouth moist. The major salivary glands are activated by parasympathetic nervous system, and that's in response to ingested food that triggers chemoreceptors and mechanical receptors in the mouth. They send signals to the salivatory nuclei in the brainstem that stimulate parasympathetic impulses in fibers in cranial nerves 7 and 9. There's a strong sympathetic stimulation that inhibits too strong a sympathetic stimulation will inhibit salivation and leading to dry mouth. And even the smell and sight or food or an upset GI tract can stimulate the production of saliva. Decaying primary teeth can be painful and may lead to serious infections. Primary teeth deserve as much attention as permanent teeth. Primary teeth are important as placeholders for the developing permanent teeth, and primary teeth can be kept healthy by brushing, limiting exposure to sugary liquids, and from prolonged bottle feeding. So that brings us to the teeth. The teeth lie in sockets and gum-covered margins of the mandible and maxilla. They're involved in mastication, which is the process of chewing and tearing and grinding food into smaller fragments. There is a dental formula that dentists and hygienists use and healthcare professionals use to map the teeth. I'm going to go through it quickly, but it's not something most of us will ever have to use extensively, but you should be aware of it. So the dentation means how we get our teeth. In primary dentation, we have 20 deciduous teeth. If you are familiar with trees, you know that deciduous trees lose their leaves in the fall, and so deciduous teeth fall out. They are also referred to as milk teeth or baby teeth. They erupt between 6 and 24 months of age, and they will eventually fall out somewhere between 6 and 12 years of age. Below those, there are 32 deep-lying permanent teeth that are in the process of enlarging and developing, while the roots of the milk teeth are being resorbed from below, which would cause them to loosen and fall out. All but the third molars, which are also called the wisdom teeth, are in by the end of adolescence. It may take quite a while for the third molars to emerge, somewhere between the ages of 17 and 25. Teeth are classified according to their shape. There are incisors, which are chisel shape for cutting. Canines, which are fang-like, that are good for tearing and piercing. And premolars, which are bicuspids. They have a very broad crown, rounded cusps, and they are used to grind and crush. The molars are the broad crown, rounded cusps that are the best grinders. They're used during chewing. Upper and lower molars lock together, creating a tremendous crushing force. And those are mapped out, our deciduous teeth here and our permanent teeth below. So that dental formula, which is a shorthand for indicating the number and position of a teeth, shows the ratio of upper to lower teeth for only one half of the mouth. The other side is the mirror image. So in the primary, we would have 2 incisors, one canine, and 2 molars in the upper jaw. And on the lower jaw, you would have 2 incisors, 1 canine, 2 molars, and that would give you 5 here, so 10. You get that on both sides. You get 20 teeth. You do the same thing with permanent teeth. In permanent teeth, we have 2 incisors, 1 canine, 2 premolars, and 3 molars on the top and on the bottom, one side of the mouth. So you get a total of 32 teeth. Each tooth has 2 major regions. The crown, we already mentioned before, is the exposed part above the gingiva, which is the gum. It's covered by enamel. Enamel is the hardest substance in the body. It is not bone, but it's actually harder than bone. It's heavily mineralized with calcium salts and hydroxyapatite crystals. The cells that produce enamel degenerate when the tooth erupts, so you cannot replace enamel. If it decays or cracks, you need to artificially repair it by filling. The root is the portion of the tooth that is embedded in the jawbone. It connects the crown. It's connected to the crown by the structure called the neck. Canines, incisors, and premolars have one root. The first upper premolar often has two. First upper molars have three roots. The first two lower molars have two roots. And the third molars, the roots vary. Often it's a single fused root. Cement is calcified connective tissue that covers the root. It attaches it to the periodontal ligament, and the periodontal ligament forms the fibrous joint called a gomphosis. We talked about it when we talked about joints. It anchors the tooth into a bony socket. That bony socket is called an alveolus. Gingival sulcus is the groove where the gingiva borders the tooth, and dentin is a bone-like material underneath the enamel. And that is maintained by odontoblasts, and those odontoblasts are found within the pulp cavity. That pulp cavity is surrounded by dentin. It contains pulp, which is connective tissue, blood vessels, and nerves. The root canal is the cavity that extends to the root. It is also the name of a dental procedure that is done to kill that pulp when it becomes infected. The apical foramen is at the proximal end of the root, and that is the entry point for blood vessels, nerves, etc. So here is our pulp cavity, root canal, and the apical foramen. An impacted tooth is a tooth that remains trapped in the jawbone. That can cause a good deal of pressure and pain. Wisdom teeth are typically most common ones involved with impacted teeth, and they need to be removed surgically when that happens. Dental caries are cavities. That's the demineralization of enamel and dentin, usually by a bacterial action. They form dental plaques, which are called biofilms. They contain sugars, bacteria, and debris. They are really on the verge of a living substance. They adhere to the teeth. The bacteria produce acid. That acid dissolves calcium salts. Proteolytic enzymes would then digest the organic matter from them. The only way to prevent these is daily brushing and flossing, as well as regular visits to a dental hygienist. Gingivitis happens when the plaque calcifies to form a structure called calculus or tartar. Calculus disrupts that seal between the gingiva and the teeth, and that allows anaerobic bacteria to get in and infect the gums. Anaerobic bacteria do not like oxygen, so they get into that space where there's little oxygen. They grow nicely. That infection is reversible as long as the calculus is removed, the tartar is removed. Periodontitis or periodontal disease happens when you neglect the gingivitis and it escalates to disease. Immune cells attack the bacterial intruders, but they can also damage body tissues, can destroy periodontal ligaments. That can activate osteoclasts, which can lead to the dissolving of the bone, losing the tooth that way. Certainly there is evidence that it increases our risk for heart disease and stroke, and possibly through the arteriosclerotic plaque formation, which is not the same as the plaque we talked about a few moments ago. Bacteria can get into the blood in addition to that and cause clot formation in coronary and cerebral arteries. Risk factors for periodontitis include smoking, diabetes, mellitus, and even oral piercings. All right, that takes care of the mouth. We'll move on with lower structures in the next set of slides.